Today's topic is on acute renal failure, and the class will be taken by Dr. Sangshaptak Saha. He is an MBBS, MD, DNB, DN, AIMS, New Delhi, MRCP, London, Associate Consultant, Critical Care Medicine, Apollo, Kolkata. So, sir, now I hand over the class to you.
So we shall first discuss around 24-25 questions, and then the last 10-15 minutes I shall quickly discuss about a few other topics if we have some time. And of course, with each of the questions, we shall discuss the answers and and how to rule out the other answers in detail. This is a crash course, so we shall not go into much depth. We shall just discuss the basic questions and answers and 2-3 minutes about each topic. So just go through this question once. All of these are like previous year's questions, or at least the topics are of last 3-4 years of EDIC part 1. So first 2-3 questions I shall also go with you just to get the thing started. So 54-year-old man who has got a diagnosis of Burkitt's lymphoma now has come with electrolyte derangements and acute renal failure. He has got these electrolyte values: potassium, phosphate, calcium, uric acid are given. I think everybody, all of us knows what the condition is. He's treated with Burkitt's lymphoma, probably on chemotherapy, and now he has developed a syndrome called tumor lysis syndrome. So there is hyperkalemia, hyperphosphatemia, hypocalcemia with hyperuricemia. So just go through. So they have asked which is the least true. So the 2 options are here, and the other options are here. Please go through it. I will give you 30 seconds, and then we shall discuss about the answers and a bit of tumor lysis syndrome as well. So, like, what is tumor lysis syndrome? So can you just share the answers on the chat box, please? Or you can just open your mic and tell. Okay. I mean, somebody comment something. The answer is pretty straightforward, I think. Okay, we shall just discuss the first answer so that everybody gets more comfortable. So they have asked which is least true. So basically they have asked for the treatment of tumor lysis syndrome. So we shall discuss just 2 lines. Tumor lysis syndrome was something which is most common in high-grade Burkitt's lymphoma and in ALL. So it can happen in any malignancy, but Burkitt's is classically associated with it. Spontaneously, it can happen after a chemotherapy, or it can happen on its own as well because of the high tumor load. New drugs associated are because we are getting more drugs like steroids and the opiate and the Zuma group of drugs, so it's happening more and more. Cairo Bishop is a criteria. There are 2 parts: laboratory criteria and the clinical criteria. Laboratory criteria involves the ones which are given here: uric acid, phosphate, potassium, and calcium. Classically, hypocalcemia with hyperphosphatemia is the classical finding with hyperkalemia. And clinical findings are whether there is any arrhythmia, that is cardiac arrhythmias, seizures, or if there is any AKI, acute kidney injury, that is rise in creatinine. Most common ones are acute myeloid leukemia, chronic lymphocytic leukemia, and non-Hodgkin's lymphoma. And what is the treatment? Treatment is mostly supportive management, IV hydration, and use of hypouremic agents like allopurinol, rasburicase, and febuxostat. Among them, allopurinol is a classical agent, rasburicase is a new agent, but rasburicase decreases this load, uric acid load, more than allopurinol. But mortality-wise or morbidity-wise, none is better than the other. The main goal of hydration is to get an adequate urine output, to do it over next 24 to 48 hours to improve the renal perfusion. Sorry. Urinary alkalinization, there is no role. And among the hypouricemic agents, allopurinol, it inhibits xanthine oxidase. Rasburicase, it is a recombinant urate oxidase. And febuxostat inhibits oxidize and reduce both this xanthine oxidase. So here, what options they have given: They are told that there should be complete correction of electrolyte derangement fluids. It occurs with increased frequency in bulky, rapidly proliferating tumors, which is obviously correct. Electrolyte derangements occur because of tumor lysis, that is also correct. Treatment with rasburicase is more effective at reducing the uric acid levels in allopurinol, which is correct. But option E, that the treatment with rasburicase is not more effective in preventing death or preventing or decreasing the other symptoms of tumor lysis syndrome. So only because they have told that it is good at reducing uric acid levels more than allopurinol, that's why it is correct. Otherwise, the list 2 is option A. Complete correction is not needed. Incomplete correction, is partial correction, is good enough. This is second question. Second question, first the diagnosis. Just go through it once, 30 seconds. Then we shall discuss the condition. Yeah. So this patient was unconscious in the park for some time, and now she has dark colored urine. As EDIC aspirants, we all know that this signifies that the patient is suffering from myoglobinuria, right? So which of the following is expected on the ABG? I think you're more comfortable now. Can somebody write down the correct answer in the chat box? Yeah, people have written down. Yeah, it's rhabdo, real-time postulation. Yes, due to treatment of options. Circulation, yes. Rhabdomyolysis, yes. So let's see what is option B. I think everybody can see the screen and the options right now, right? So option B is metabolic acidosis, low calcium, high phosphate. And that is obviously the correct answer. Just a continuation of the last question that we discussed. Okay. So they have shown an ECG here. The ECG is quite straightforward. It is a, just somebody tell me what it is. It is a, okay. So somebody tell me what is the ECG finding is. It's showing a, yeah, it's showing a tall T wave. So which is the next best step in management. Now this was a huge scenario. I have not written down the whole thing. At the end was this ECG. I think in the question, because in EDIC you have to write a number of questions. The questions are not very difficult, honestly. If somebody prepares for 2-3 months, then it's relatively should be easy to crack. The only problem is the time management. So if this, I have intentionally not used the whole paragraph because it was at least 7-8 lines question. At the end, there was this ECG. This ECG alone for an EDIC aspirant is enough to tell that the patient is suffering from hyperkalemia and their ECG changes. So which is the next best step in management? Okay, keep the answer now. Tall tented TOFs, obviously, and option B. What is option B? Option B is IV insulin. Okay. Everybody agrees with option B? Okay. Nice to see that somebody has given option A also. Yes, Dr. Swati and the other doctor who has written option A. Obviously, it's option A, right? Because look, yeah, let's clear the concept here now. This patient has got hyperkalemia and he or she is suffering from some medical condition, probably acute renal failure or CKD, and there are ECG changes. The next best step has to be calcium gluconate, because calcium gluconate will not treat the hyperkalemia. That I think we all know. That's why people are going for option B. But here, stabilization of the cardiac myocardium, that is the myocardium, the cardiac membrane, that is the first step. That is the most important step. And along with it, obviously, you have to give IV insulin with dextrose to prevent hypoglycemia. So calcium gluconate next best step, because the first step is preventing further arrhythmia, because this can very well progress to VT or an AF. So that we have to prevent first. So the first next best step is calcium gluconate. If they are specifically asked what is the next best step for managing the hyperkalemia or to reduce the potassium level, then yes, then it will have been IV insulin. But this question classically comes like this, so that the people like are misguided and they write down IV insulin, because everybody knows that calcium gluconate, it does not prevent the hyperkalemia, not for the hyperkalemia, but for stabilization of the myocardium, to prevent arrhythmias, right? So option A, that is calcium gluconate, is the right answer, not option B, because of the subtle difference in the what they've asked. So it's very important to read the question, to and also to read what they've asked, because hyperkalemia management everybody knows. Everybody throughout the world who is appearing for EDIC knows how to manage hyperkalemia. That is not a point, but be very careful reading the last line. So in EDIC, yes, read the paragraph also, but read the last line very carefully. Don't hurry to the last lines or the graph or the images that they've given, because often that is enough. Because here, if somebody makes it that there is a tall tented T wave and next base to calcium gluconate, it will take 15 seconds. And if you go through the 7 line stanza, it will take probably 1 minute. So save time as much as you can. Okay. Moving on to the next question. USG Doppler parameters. Now, USG Doppler parameters was something that EDIC was not commonly asked, but in the last 2-3 years, the year before that, I gave the exam, and I gave the exam. So 4 years running, they have asked for this USG Doppler parameters as well. That's why I have included 2-3 questions on this. So we shall discuss USG Doppler parameters. Just go through this question. If somebody knows about it, then answer. Otherwise, it's fine. We shall discuss anyway, because it's not something that is common in the EDIC question previously, but now it's coming up because we are using it clinically and practically on everyday ICU to practice. That's why it is coming up in their question format as well. And they've also included it in their crash course that the ESICM does. So I shall just check if somebody has replied something. Option C. So they have asked which is false about the renal parameters. So the moment they ask which is false, our aim becomes different. So now our aim is to rule out the other options. So first is they have asked RRI. What is RRI? RRI is renal resistance index or renal resistive index. So that is one of the USG Doppler parameters. So that is true. That is not the answer. Now, can be measured in patients unable to breathe hold. Now, kidney is a retroperitoneal organ. So whenever we are inspiring or expiring, its position, at least in the USG, changes with that. So it's mandatory the patient should be able to breathe hold. That is why in our ICU, in a patient, I work in a respiratory ICU where respiratory patients are more. It is very difficult to diagnose, to get these renal Doppler parameters done in the case of API, because the patients are already tachypneic. So they're not able to breathe hold, right? In a case of acute bronchial asthma or COPD or even lung malignancy patients, it's very difficult to ask them to breathe hold. So they're not able to breathe hold, and it's very difficult to get a USG Doppler parameter renal done. So option B is the answer here, because that is false. It cannot be done in a patient who is unable to breathe hold. Definitive cutoff values are definitely available, and it correlates with clinical parameters as well. Okay. So this was the first question on USG Doppler parameters, and we shall just okay. So there are a few other questions also. We shall also discuss them, and then we shall discuss a few 2 minutes on USG Doppler parameters. Next question is FST, furosemide challenge test or furosemide stress test. So which is not true? I think it's a very common question. It's a classic EDIC question, and I shall check. But yeah, first go through the question, 30 seconds. So the first option is Lasix means if the patient is receiving Lasix naive means patient has never received Lasix. The dose varies with that. The second option is what is the minimal urine output that is required to prove that yes, the Lasix is working. The third is the part of the kidney which Lasix works on, the furosemide works upon. And the fourth is equivalent to biomarkers. So let's see which is true, rather which is false. Okay, has somebody answered? Okay, I think everybody has gone for option D. It is not equivalent to biomarkers, right? Furosemide challenge test or the furosemide stress test is not equivalent to biomarkers because the biomarkers have not been validated. We shall discuss the biomarkers in detail. The next 3-4 questions I have given all the 4 biomarkers that EDIC asks for, or what is available on the EDIC modules, so that there is no confusion. But FST is not equivalent to biomarkers. FST is a standard test which is also FDA approved, and using day-to-day practice, it is not equivalent to biomarkers. Okay. Now somebody has told that the first option is false. So if the patient is on Lasix 1.5 milligram per kg IV and the patient is Lasix needs 1 milligram per kg IV, right? So what do you think? It is true or is it false? Let's see if somebody else has also given out the answer or not. The first option. Okay. First option, somebody has told that Dr. Sohail has told that it is true. Right? Second option. Somebody has told that second option is false. Why so? 200 milliliter urine per hour for 2 hours. Second option. Okay. So it's the second option is actually false because it's 200 ml urine over 2 hours. In 2 hours, it's 200 ml urine. First hour 80 ml, second hour 120 ml is fine. Every hour it need not be 200 ml. So that is false. Option C is obviously true. That is site where it was. Option D I explained. So here option B and D both are false. Now, okay, before we move on to the biomarkers, a bit about renal Doppler ultrasonography. There are 2-3 indexes in my DM critical care which I've done from AIIMS Delhi. My DM thesis topic is also on this renal perfusion, but we shall not obviously not go into those things. We'll just focus on the question asked in EDIC, which is renal resistive index. 3-4 things you need to know. First, it cannot be done in case of patient is unable to breath hold. Second, it is done at the level of interlobar vessels, not at the renal artery or renal vein. What is the formula? We have to do a renal ultrasound and we have to do it in the Doppler mode. Then we get both the systolic and the diastolic velocity. It is the peak systolic velocity minus the end diastolic velocity divided by the peak systolic velocity. The normal value of RRI is 0.5 to 0.7. If RRI is less than 0.71 but more than 0.5, then it is transient AKI. If RRI is more than 0.8, it is persistent AKI. And if it is RRI is more than 0.74, then 3.3 times the risk of developing AKI at day 5. So what you need to know is it is not only used for diagnosing AKI, but also for whether it is transient or persistent depending upon the value. RRI more than 0.8 is persistent AKI and more than 0.71 but less than 0.8 may be transient AKI. Whereas RRI more than 0.75 means, and suppose the patient now has got a normal urea creatinine, but the patient has gone into septic shock, or patient is severely hypovolemic, and we expect that the patient may go into AKI, acute kidney injury. Even then, if you do an RRI and if it comes more than 0.75, even if the urea creatinine values are still normal, even then there is a more than 3 times the higher risk of developing AKI by day 5. So also for prediction of AKI, even if the patient now does not have AKI. So there are 3 uses of RRI. This is the one which they asked. Can it be used for predicting AKI? Yes. Can it be used for differentiating transient and persistent AKI? Yes. Can it be done at the level of renal artery or at the interlobar or interlobular vessels? It can be done at the level of interlobar or interlobular, not at the renal or renal artery. So the smaller vessels are needed. So you need to be a bit of an expert in the renal ultrasound scan. Otherwise, it cannot be done. And of course, it can be done if the patient is able to breath hold or if the patient is sedated paralyzed. Otherwise, it cannot be done. So that was about RRI. Now, obviously, we have now moved on to the renal biomarkers. I think you have got enough time to read the question. Key means kidney injury molecule 1. We shall discuss about NGAL and TIMP to IGFP7 also, but first KIM 1. So which is true about KIM 1? So kidney injury molecule. So what are the biomarkers? Biomarkers are now a hot favorite with EDIC. Okay. Just write down whatever you feel is the correct answer here, or which options are false We shall discuss. A few of the question intentionally there are more than one false, more than one correct answer, so that we can discuss about each of the options. Because anyway, we shall be doing exactly that. Okay. So Dr. Sohail has told it is true, false, true, true. So option B is false. So kidney injury molecule 1, as a name suggests, only comes in the urine if there is a renal injury. So option A is right. Option C, FDA approved biomarker. It is not an FDA approved biomarker, as I have just told in the last question. There are two FDA approved biomarkers. Chemo is not one of them. Upregulated in PCT. That is true. It is upregulated in a proximal convoluted tubule, and that's why in a case of PCT injury, it is a chemo value increases more. Now, obviously, if there is a PCT injury, there can also be a DCT injury. So then it can be rising in both PCT and DCT injury. But if the injury is only at the level of distal convoluted tubule, then chemo may not rise, and that is the problem with chemo. Because regardless of whether the patient has got a PCT injury or DCT injury, the clinical outcome is the patient has got an AKI. But if there is only an isolated distal convoluted tubule injury or glomerular injury, then this chemo may not rise, and that is the problem, and that is why it is not FDA approved biomarker. Because anyway, biomarkers are not that widely used, and we have got better biomarkers in chemo. Remember, chemo has come in the question previously, and chemo is there in the EDIC module on AKI as well. So just because it is not used does not mean that it is not very important, but it is frequently asked in the exam. Now coming to NGAL. NGAL, what is NGAL? NGAL is one of the other biomarkers. Just go through the options. We shall discuss NGAL in a bit more detail than chemo because it has come more frequently. Okay. Yes, Dr. Soil, I shall just tell you which is FDA approved as you go through the other questions. Don't worry. Okay. So I think we shall discuss NGAL first and then we shall go for the answer, because I don't think many of the aspirants know about NGAL that much. So NGAL is a protein which binds to the neutrophils. It is neutrophil gelatinase associated lipocalin, the full form. It is a damage marker. It is a marker of tubular inflammation, and it is produced by neutrophils as well as the renal tubules, the thick ascending limb mostly. NGAL is detectable in urine 2 to 3 hours after the AKI has set in, and plasma NGAL also increases in AKI. So option B is correct. Option A is it's a bedside test. Option C is impaired tubular reabsorption has got no effect, but NGAL is produced by neutrophils and tubules. So yes, of course, impaired tubular reabsorption will have some effect, and it increases in both infection and inflammation. That is also correct. Even if there is a renal tubular injury or renal tubular inflammation, like glomerulonephritis, then it can also increase. It has a role in diagnosis as well as severity. Why? Why the diagnosis we know, but why severity? Because it has been validated in cardiac surgery, where the NGAL values less than normal value less than 50. But if the NGAL value rises, and if it is more than 100 or less than 200, then it can be mild. If it is less than 200, more than 200, less than 1000, then it is moderate or grade 2, and more than 1000 picograms per ml, it is severe. So there is a grading. No need to remember the values. Just remember that in case of cardiac surgery, post cardiac surgery, AKI chance very much increases, and in them there has been a grading which grades on the basis of this NGAL the chance of renal injury. So it is also used for grading the severity of the AKI. Yes. So it can be increased in sepsis, septic shock, and also in burns. So it is not specific. So you have to remember that it is a damage marker. It can be used for diagnosis as well as severity, validated in cardiac injury, cardiac surgery patients, plasma NGAL, urine NGAL both increases, and increases 2 to 3 hours after. That much is enough. Next is the third biomarker, TIMP2 IGF-BP7. Once again, I shall directly discuss this thing because it's not very common. So this one is only for urine, not for plasma. One difference. Second difference, TIMP2 is tissue metalloproteinase 2, IGFBP7 is insulin-like growth factor beta binding protein 7. It is a stress marker, so it can be used for prediction of AKI also. So NGAL KIM1 cannot be used for prediction of AKI. This one can be used for prediction of AKI as well as for diagnosis and severity. And it is an FDA approved biomarker for AKI stage 2 and stage 3 within 12 hours of injury in critically ill patients with cardiac and respiratory failure. So as your long-standing query, which one is FDA approved? This is the one which is FDA approved. TIMP2 IGFBP7. Now, why were we writing it together? This is because there is something called a nephro check test, where we are getting the individual values of TMP2 and IGFP7 and then we are multiplying it. Okay, we are multiplying it, and if the value is more than 0.3, then it is positive. If the value is less than 0.3, it is negative. If the value is less than 0.3, then there is a very low injury, less chance of an AKI developing. If the value is more than 0.3, then there is a high chance of AKI within 12 hours. So option A involved, yes, another thing. These metalloproteinases, these are released during cell cycle arrest, which is G1 phase. So that is correct. It is involved in G1 phase cell cycle. Above 0.3, we have already discussed the cutoff is 0.3. Option C we discussed, the time limit is 12 hours. And option D is the marker of cell injury only. It is not a marker of cell injury only. It can be used to predict as well as for diagnosis and for severity. And it is validated by FDA. The trial name is Saha study, which is not needed for your level. I just gave that out because of the information. Anyway, so these are the three biomarkers which you shall require in the for EDIC. KIM1, NGAL, and this one. Biomarkers can be three parts. It can be marker of glomerular function, tubular function or tubular injury, and inflammation and repair. Creatinine is for the glomerular function. The ones you discussed all are for tubular function. And marker of inflammation are the calprotectin, interleukins, those things. I think this much information enough for EDIC part 1. So coming to hemodialysis in ICU. Early hemodialysis in ICU, which one is false? Just go through the options. You need to know a few trials. Now, 2-3 trials for EDIC 1, because this early hemodialysis or late hemodialysis is a long-standing debate with the nephrologist and the critical care physician. I have to debate it every day in the ICU, and so we shall discuss it. So early age in ICU, which is false. There is no change in mortality, which is true. Okay. We shall discuss. There is decreased risk of RRT dependence, which once again is true. There is increased risk of infections, which is true. And super late initiation has shown benefits, which is false. So there are trials like the ACICI trial, ACICI 2 trials, which have shown that early versus late. That is, early means as soon as the patient has got an AKI, we are starting it. Late means we are waiting for some renal, for hyperkalemia, for severe metabolic acidosis, for the urine, for anuria, or for this what do you call it? Oliguria, oliguria for more than 72 hours before you're going for hemodialysis. Nice. We have shown that there is no mortality benefit, there is no morbidity benefit. Rather, if you are going for early HD initiation, then there is a higher risk of RRT dependence. So that patient may become CKD dependent. So may require maintenance hemodialysis. Whereas studies have shown if we withhold the dialysis, if we medically manage the patient, if we give some Lasix, if we give some fluids, if we correct the sepsis, if we correct the underlying cause, then that patient may not require RRT for the rest of his life. So option B is false. Option C, increased infection because of the lines, because of the fistula that we require for initiation of dialysis, that is obvious. and superlet initial non-show benefit because we should not wait beyond a certain period of time. So that is the question. This question once again came during my EDIC, the one which I gave in 2016, 2019. So it's a classic example. Again, rash with fluffy opacities on chest X-ray AKI. So, doctor, what is the diagnosis here? What is this group of syndrome called? Tell me that first. Right, Dr. Sohel. NGAL in AKI is as proper in ACS. Proper in ACS, as we know, ACS, if the patient has ACS, proper will be increased. But even if the patient does not have ACS, proper can be increased in a lot of other conditions. Similarly, NGAL, it can be increased in a lot of other conditions, not only in AKI. So it is not specific. Very good, doctor. Dr. Archana, you have told it is option D, and Dr. Sohel once again has told that it is a renal pulmonary syndrome. Yes, it is a pulmonary renal syndrome. Dr. Sohel is right. And option D, good postures. Yes, rash with fluffy opacities on chest X-ray with AKI. It is good posture because it is pulmonary hemorrhage with AKI because of renal hemorrhage as well. Option A is GPA. GPA is microvascular condition. So that can also present with rash with fluffy opacities with AKI. But fluffy opacities, classically, if you have to select one option, it is good posture because of pulmonary hemorrhage. LRTI, HSP is henoxyclone purpura, which presents with rash, but that is not a single best option here because it can present with opacities and AKI, but better is good postures, obviously. Now, what are the signs of renal recovery? You go through the question, I shall just be commenting a few lines. Good signs of renal recovery, it can be clinical. Patient is improving, sepsis is improving, we have removed the stones, we have removed the obstruction, one thing. Secondly, patient is powdering urine, obviously. The color of the urine has changed. We have done an USG and it is showing the kidney is no longer shrunken, the hydronephrosis is no longer there, the stone has passed out. Or you have done a renal Doppler and we have discussed RRI, renal resistive index, found that the value is less than 0.7. Or we have ruled out hypoxia, hypotension. We have maintained a good MAP of 70-75. We have maintained a good PO2 level of above 65-70, and we have prevented hypoxia. And so good signs of renal recovery. This question I included mostly to discuss this part. Renal resistive index we have discussed. Pre-renal causes has to be sorted out. It is a hot favorite with the EDIC questions. That pre-renal causes, hypovolemia, sepsis, hypotension, hypoxemia, these needs to be corrected. CMD loss on USG is obviously a bad sign. That is one of the diagnostic features of CKD. So option C is not correct. Option D, hypoxia, hypotension episode, we need to prevent. If there is hypoxia, hypotension, then there is more chances of AKI, progressive to persistent AKI, and worse feature of renal recovery. CI AKI, contrast-induced AKI. Which of the following is not true? You give the answer, I shall discuss it. CI AKI, doctor, once again, is a very common topic. Last two EDIC my friends have given, I think more than one question came out of CI AKI. So yeah, I'm mentioning the frequency which is coming, so you guys can just give it, because all of this is a crash course, right? We won't be discussing these things in details right now, because all of you know this. But if you have to mention 2-3 points on AKI, then CI AKI is one of them. Second one is the biomarkers. Third one is the definition of AKI, which we shall discuss it. I have included a few questions to discuss. So which of the following is not true? IVF alone prevents it. Low osmolar agents have been equivocal to medium osmolar agents. Usually happens in 5 days. No treatment found to be non-inferior. Option C and option D are correct because no treatment has been found to be superior or inferior to IV fluids. Happens in 5 days also correct. Usually be 2 to 3 days, maximum 5 days. After 5 days, if AKI is occurring and the features are of like contrast-induced AKI, then it is more chance of cholesterol embolism. It is an MRCP question, not an EDIC question as such, so not included cholesterol embolism here. But beyond 5 days, it won't be CI AKI. Option B is a classic new finding. It is one of the hot topics, not only for EDIC, but also for any critical care question. Low osmolar agents are not equivocal to medium osmolar agents. Low osmolar agents are better than medium osmolar agents. So if you have to prevent CIAKI, the first option is to avoid the contrast agents. And even if you have to use it, use the low osmolar agents, not the medium osmolar agents, because low osmolar agents are better. They cause less of contrast-induced AKI. And IVF alone prevention is absolutely correct. You have to hydrate the patient previously. And in the practical life also, you have seen that even the creatinine is 1.4, 1.5, and suppose there is an urgent indication for a pulmonary embolism, you have to do a CTPA. You cannot wait for the CTPA, right? Otherwise, the patient is stable. So we give 1.5 to 2 liters IV fluids. We maintain the IV fluid during the procedure, and then we give 1 liter after the procedure. And usually, the patient do not develop AKI. So IVF alone, even in our small sample size studies, also have proven to be very much equivalent. Obviously, there are multi-center worldwide studies which have proven it beyond any doubt. CIAKI, just brush it up before your exam. It is very important. Which of the following is true? Goal-directed therapy in AKI improves mortality. AKI bundles in non-surgical patient improves AKI. AKI bundles in surgical patient improves AKI. And option D, we have already discussed, TIMP2 IgFP7 improved mortality in AKI. Now, option D, TIMP2 IgFBP7 is used for a lot of things, but not to improve the mortality. None of the biomarkers have shown to improve mortality in AKI. So, option D is false. Option A, goal-directed therapy, everybody uses it, like prevent hypoxia, prevent hypotension, give this much fluid, target this much positive negative net balance, but none of it is shown to improve mortality. AKI bundle used in non-surgical versus surgical patients. So as soon as you see option B and C, you know that one of them will be the answer, right? Because those are so closely related. So which one of them is the answer? So the bundle-based approach for AKI has shown to be some benefit only in surgical patients, not in non-surgical patients. So that is the answer here. AKI bundle used in surgical patients alone improves AKI incidence. This question I have made directly from the EDIC module of ESICM. Which is a drawback of creatinine used to diagnose AKI? Okay, so last topic, not last topic, but last topic to discuss in details. The other topics are mostly repeats. So we all know that to diagnose AKI, there are three criteria. There are three systems, right? One is and all of them uses the similar things: creatinine and the urine output. One is the Akin criteria, which are no longer used now. It was one of the its criteria was used previously. The other one is the KDIGO criteria, which is most commonly used now. We all know what the KDIGO criteria is, but the KDIGO criteria also uses serum creatinine and urine output levels, right? On the basis of that, there are three stages: stage 1, stage 2, stage 3, and whether the patient is on urine hemodialysis or not. There are no mortality difference as such, even if you predict whatever mode you use, because the OROC score, which is the statistical score, that have shown that all three, the mortality prediction values are 0.73 to 0.74. But the main problem is limitation of serum creatinine. So all of them are the limitations, because if the serum creatinine is obtained from the muscle mass. So if the patient is too obese or if the patient is too thin, then there will be the problem. Pregnancy, everything is deranged. There can be some rise, the GFR increases. There is a lot of washout. Creatinine decreases. So you cannot use creatinine value in a standard fashion. And the KDIGO does not mention anything regarding pregnancy either. ALI, acute liver injury. Obviously, in a case of acute liver injury, then the acute kidney injury can also occur, and you cannot use creatinine again. And in an ICU setup, this acute liver injury is very common, and then we cannot use these criteria to diagnose AKI. Drugs like dexamethasone, cefoxitin, other antibiotics, steroids, that is dexamethasone, they all interfere with AKI. And these are the antibiotics which you routinely use in an ICU. So these are the very practical problems to use the KDIGO definition of creatinine use. That's why these questions are coming up now. That creatinine is a late marker of decreased GFR. It takes time. It is an insensitive marker, in a normal and to high GFR ranges, that is in a pregnancy. KDIGO criteria requires a baseline creatinine to be known. Otherwise, how will you know whether it is 25% decrease or 50% decrease? Creatinine is a marker of kidney function, not a kidney damage. So even if the creatinine is normal, then we cannot be sure that the kidney damage not occurred because it can take some time. Besides, there is a reduced production of creatinine with decreased muscle mass with old age, fluid resuscitation, fluid overload. There is a problem. Physiologically increased GFR, like in pregnancy, we cannot use it. And if you use drugs like cefoxitin or dexamethasone, then once again there is an interference. Here we shall also discuss about the problems with urine output based criteria. So urine output criteria lacks specificity because urine output can decrease even after fasting, after surgery, after pain, after stress, lot of things, not only because of an AKI. In obese patients, if we are using an weight-based criteria, it needs to be an ideal body weight-based criteria, not the actual body weight. So we need to calculate the ideal body weight first, and then we can use the criteria in an obese patient also. Decision to initiate RRT classifies the patient in stage 3, but indications for initial RRT variable. Suppose the patient has an hyperkalemic and the patient urine output is okay, but despite that, because the patient is an RRT, we have to classify the patient as a stage 3 AKI, whereas it is absolutely not correct based upon the urine output criteria. So that is a problem, and KDIGO criteria is less useful for evaluation of renal recovery. This urine output or creatinine are not good markers for renal recovery. We have already discussed which are the good markers. We have to use them. So both urine output based criteria and creatinine based criteria are not good enough. But why do you use it? Because if you do not use these, then what else to use? Nothing has come up. The biomarkers are not that popular. They are very costly, and there are drawbacks. And obviously, you are using the USG guided Doppler based criteria, but those are not taken up that well. So these are the answers. So we shall just run through this. These are some of the questions that have been suggested by the ESICM. I found it as a PDF. I've just shared it here. A 45-year-old woman, diabetic, post-renal transplant, now has got a rise in creatinine level of more than 30%. She has taken cyclosporin. Now the patient has got an AF, and there is a drug interaction, and there is a rise in blood pressure, but now the blood pressure is okay, and the pulse is also regular. So which of the following medication most likely? So basically the patient has multiple medicines, and now the patient has AF, and we have recently started a new medicine, and which is the most commonly used medicine for AF in a case of ICU, because you are all the questions are based on ICU setup only. The most commonly used drug for management of AF in ICU is amiodarone. Amiodarone is notorious for drug interactions. Here the patient is on drugs is cyclosporin, and the answer is that one only. Yeah, absolutely, Dr. Sohel. It is option A, amiodarone. So here, a 22-year-old man with nephrotic syndrome with minimal change disease now he has deteriorated. He has noticed that despite his usual dose of furosemide, his leg edema is worse. There is some left flank pain. BP is on the higher side. You confirm a left flank pain, and these are the investigations they have given. You can see that the second last one. I shall just mark these things out. So the patient has got a nephrotic syndrome, right? So patient has got nephrotic syndrome. There is a vague left flank pain. Leg edema is worsening. A good candidate will directly can find out the cause from here when you're looking at the question. Nephrotic syndrome, has somebody given out the answer? Because you guys are giving quite good answers, obviously, because it's a crash course, so you are all read it already. Just tell me, what is the syndrome? Nephrotic syndrome, what is? Yes, DVT. It is not a DVT, right? Because the patient is having some flank pain. So it's a thrombus. So where the thrombus has occurred in relation to a nephrotic syndrome? I think you already have the answer. You're just typing it. You can just open your mic and tell, I think. Left flank pain with worsening creatinine. It's a thrombus. A thrombus is in the renal vein. It's a renal vein thrombus. Nephrotic syndrome is notorious. Nephrotic syndrome is notorious for this thrombus in different parts of our body. So that is the answer here, renal vein thrombosis. Okay, renal vein thrombosis is the answer. Acute pyelonephritis, there is no signs and symptoms of fever. WBC count is normal. That rules is out. Nephrolithiasis, they have not mentioned anything regarding nephrolithiasis. Left side renal cyst will not present with with an acute onset. And renal artery thrombosis, it can occur, but because they have told nephrotic syndrome, so vein thrombosis is much more common. Okay, so a picture-based question. In as soon as you see a picture-based question, look at the picture first. What does this rash signify? The patient has got a job as a paint factory worker with flu-like symptoms with a 3-day history of cramping abdominal pain. She has now developed a rash. Platelet count is normal, so it is not thrombocytopenia. Every information they give is important. It is not thrombocytopenia. There is a 3-day history of flu-like symptoms, and there is crampy abdominal pain. What is the condition, doctors? Has somebody already answered? Late poisoning. Yeah, because the factory worker, I'm afraid, doctor, the factory worker is not relevant here. Late poisoning, yes, it can be there, but here they have just tried to mislead a job as a paint factory worker. It is not late poisoning. It is the rash is classical for HSP. Okay, it is henoxylon purpura, and the most important condition that she can develop is pulmonary hemorrhage. It's a spot diagnosis. If you know the rash, then it's a very simple one. And the crampy abdominal pain, those things, 3-day history, that is IgA nephropathy. IgA nephropathy don't need to diagnose in an EDIC grade exam, but you have to diagnose the HSP rash. HSP rash, IgA nephropathy, all are interlinked, and this 3-day history is classical for IgA nephropathy. If it was a 2 weeks history, then it would have been post-streptococcal glomerulonephritis. The difference is of the duration of symptoms. Just go through PSGN and IgA nephropathy once and glomerulonephritis in general. Because glomerulonephritis in ICU is very common. We had a patient with good pastures, IgA nephropathy, as well as another patient with Sianka vasculitis. 3 patients in the last 2 months, I think. It's not uncommon. So here, a 45-year-old man has presented with a poor urine output. He has eaten a holiday in Thailand. Thailand, I mind you, in this EDIC or MRCP question, Thailand mentions very specific diagnosis of Thailand and Malaysia and the Southeastern Asia. I'm sorry, but it's geographical variation that they specifically look for. Suffered diarrhea about a week ago. No other significant history. Blood pressure in the lower side. He has a tachycardia. Diagnosis HUS. As I mentioned, HUS is very common in EDIC nephrology. And they have mentioned that there is a diarrhea and gram stain. So what is the diagnosis? From Thailand, HUS, diarrhea, in shock. Anybody? A specific variant of E. coli? Yeah, E. coli, doctor, exactly. But which variant? They have not asked for that in the question, but I'm just telling. It's the E0157H7 variant. That's why the patient is in shock. Otherwise, E. coli does not cause shock, right? E. coli is the most common cause of diarrhea. It doesn't cause shock. But because the patient has unfortunately has got this E. coli variant of this dangerous variant, that's why the patient is in shock and is classically associated with HSP as well. So the management is only supportive management. Give fluids if required, dialyze. Don't give antibiotics. Antibiotics is a big no because it not help. That's what they want to know. It's a bacterial infection, but antibiotics won't help. It's the fluids. Just prevent AKI. So here, just go through the question very quickly. See how to read the question. A 4-day history of abdominal pain. So acute history, abdominal pain, you immediately think of abdominal sepsis or not. Increase urinary frequency. So immediately you understand that this is the patient of UTI. 39.2 degrees Celsius. So pyrexia is there. Tachycardia is there. Hypotension is there. So UTI and in shock. He is catheterized and there is some residual urine. There is superlative tenderness. The patient suffers from alcoholic liver disease. He smokes cigarettes and there are multiple spider nevi, right? CRP is 244. WBC count is 22.7. Very much increase. CRP increase, WBC count is increased, and there are brown granular cast in urine. They have mentioned everything in the next paragraph, but I won't go there. What does brown granular cast in urine signifies, doctors? Come on. There's only one diagnosis if there's a brown granular cast in urine, at least in an exam, not in practical life, practical ICU life, but in exam. Yes, pyelonephritis, doctor. That's quite obvious. But still, yes, it's a good answer. Can you tell me what are the granular cast in urine occurs? It doesn't. It is not specific to pyelonephritis, right? Yes, exactly. It's specific for acute tubular necrosis. Very good. Very good. You guys are quite well prepared, at least from the nephrology side of view. So as you can see, they have already given out the answer. They don't want whether the pyelonephritis or not. Pyelonephritis without hydronephrosis. So which is the most likely cause? So obviously, doctor has already given it's acute tubular necrosis, which you have to diagnose from this answer, brown granular cast. So do not spend a lot of time reading the paragraph and reading all the investigation. Just go through it quickly once. There may be one line, two line given, which will clinch the diagnosis, clinch the answer. Then no need to go through it again. Yes, if you cannot understand at the end, then go through it a bit slowly. But believe me, at least 5 to 6 questions, which means at least 3 to 4 minutes in an EDIC question is like 1 gram of diamond. It's more pricey than that. So save that 3, 4, 5 minutes, whatever you can for the EDIC exam, because the exam is simple. It's only time management that matters. Practice MCQs. No need to go for theory right now. Practice MCQs. If you cannot repeatedly have problems in a particular topic, go through that topic, not go through the whole of nephrology for no reason. At least the ones who are participating here, you guys are good enough prepared. Just practice more. Okay, next question, because I think I'm running out of time once again. Yeah. So I shall go more quickly. 80-year-old woman fell and fractured distal radius. She takes a lot of medicines, topical ibuprofen, oral paracetamol, no other regular medicines. So they are focusing on the medicines part. You have to immediately understand that they are more focusing on the medicine part. So the answer is probably something related to medicines. They have mentioned that ANA is 1/40, urine, dipstick, blood is positive, protein is positive. So it is nephritic, right? Immediately to diagnose it is nephritic because of the blood. If there was no blood, it could have been nephrotic, but there is blood, so it is nephritic. Complements are more or less okay, so that is not a problem. And they have mentioned a classical view of the kidney. This is the kidney, and with a good CMD differentiation, right? It's an excellent CMD differentiation, so there is no CKD, ruling out CKD as well. So even before you go to the answers, you may have to make this as you read the question, because NEDIC means you guys are 2 years experience in ICU, so you have to answer in that way. So the first question is drug induced PIN. Even before reading the other options, I think that is the answer. Obstructive uropathy, there is no stone, so it is not obstructive uropathy, there is no hydronephrosis. Lupus nephritis, ANA is borderline, it is not lupus, and the complements are okay. Multiple myeloma, obviously there is no clue for multiple myeloma here. Pre-renal, they have not mentioned anything about sepsis or about less volume, hypoxemia. So yeah, it's only pre-renal acute kidney injury. They have given an option about a lot of drugs, topical ibuprofen, and past medical history of aching hips and knees. So probably osteoarthritis, so probably misuse of these NSAIDs that have led to this condition. Okay. This is once again a past question from EDIC. Sorry. Yeah. So here they have given some that 50-year-old woman, 4-year history of type 2 DM, comments on 5 milligram lisinopril. Otherwise, she is well now. So this is today's result. This is 5 weeks ago results. Creatinine has started to increase, not very much increased. Urea is again in a normal value. So only rise in creat is there. And the only condition that happens in EDIC exam is if the patient is on new onset ACE inhibitors, because there is a 30% rise in creat, which normally occurs. That is not in AKI. So most likely cause for the electrolyte changes. Progression of diabetic nephropathy. HbA1c doctor is 7.1, normally 7%. So this is not the answer. Renal artery stenosis presents in a completely different way. Unregulated hypertension and those things not present here. Diabetic ketoacidosis, they have not mentioned anything to suggest. And hypertension. Her blood pressure is not bad. Her blood pressure 181, so it's only hypertension. So it is the starting of ACE inhibitors, lisinopril, as they mentioned here. So here the patient is from Ghana. He is a live renal transplant patient 3 weeks ago. Currently, he is on a lot of these medicines and there are no complications of the procedure. 2 days back, creatinine level was 155. Now creatinine 165. So what has happened? What investigation will confirm the acute rejection? It is there is only one thing correct answer here, that is the renal biopsy. So acute kidney injury, acute rejection, the answer renal biopsy. No need to go through any other option. So here, even if you have not read this whole thing, and if you're directly read about this, the acute rejection, even then your option has been option C. So read the last line first. In some cases, make it a habit, you will benefit. You will know which ones to read first, which one not to read first. Make it a habit, then you will benefit from it. Directly in the exam, if you start doing it, you won't benefit. Most likely to be affected by a sudden fall, the answer dabigatran. It's the theoretical question. There is no explanation. Dabigatran is more affected. Okay. So here the patient has got pyrexia, left renal colic, and ultrasound conducted left hydronephrosis. So there is a pyelonephritis. Left ureteric stone. So there is a stone, 1.5 centimeter. Hemodynamically, she is stable. Her temperature is 38 degrees Celsius. Left lung pain. Most appropriate intervention. Okay. Rehydration, lithotripsy, nephrostomy, stenting, scopy, stone removal. I think for your level, its answer is obvious. There is a stone which is probably causing this, so you have to remove the stone. So you have to go for the stone removal, uteroscopy, and stenting. Now option D and option E both are partially correct. Option E is the more better option because stenting is always after the removal of the stone, right? So removal of the stone has to be part of the answer. You cannot go only for stenting. Otherwise, all three are done. But because we have to remove the stone, so option E is the better choice, not option D. Yeah. Nobody has told anything on the chat. Sorry. Just go through this. Go through it like I am going through it. I'm just going through that so that you can know how to go through that, how to read the question. Because reading the question is also an art. Leaves alone was found collapsed on the floor. So the diagnosis in an exam is rhabdomyolysis, irrespective of whatever they have written. Okay, you have to diagnose that first. For many hours, the same thing. Now he is in shock. Blood pressure, pulse, he is febrile. Resuscitation started. Some fluids was given. Calcium, IV glucose, reduce the potassium. In spite of catheter, does not pass urine. So he is anuric. There is a rise in potassium, and they have given the medical management. Write down these notes in your brain as you do the question and answer very fast. So what they have asked? They have asked which of the following is the most likely to improve his outcome. So this is a very classic question. Can somebody just tell me the answer? His potassium after the correction is 6.7. That is the only clue for solving the answer. Rhabdomyolysis is anodic medical management for treating the hyperkalemia. Despite that, potassium level is still high. What is the next best step to improve the outcome? Come on, it's a challenge. Okay, Dr. Sohail has written, others also participate now because there's no fault in giving out a wrong answer here. If you give a wrong answer, then I can pick out the what mistake you guys are making. So both of them told option A and yes. This is the difference. Last week I was teaching an MRCP class on nephrology, and they are much more juniors than you guys. I think they were more on the favor of this further intravenous calcium supplementation, those type of things. Here straight away you have guys told it option A, and that is the obvious option here because it is a refractory to medical management of hyperkalemia. Refractory to medical, some people may not know this, but refractory to minimal management of hyperkalemia, the only thing which will not only improve the outcome but save life is hemodialysis. That is the only thing that will not only improve outcome but save life. Okay, so the option is hemodialysis. Very well done. Both the options which I've told you. If you guys were in ICU, you would have saved somebody. These are life savings. Anyway, 23-year-old man attends his GP complaining of reducing exercise tolerance. He also had generalized body pain. He had a contrast angio done 1 week back. So contrast angiography 1 week back. So can it be a contrast into AKI? You guys tell in the chat box. I shall see later. 165/90, BMI is stable. There is no tendon rigidity, abdomen distant, dullness in both flanks. Dullness in both flanks. Both. Immediately there is a problem. How can it be both? Stones, cysts, sepsis. But both flanks simultaneously. It's a bit uncommon. Let's see what they have told. Creatinine is very high. So probably a chronic process, right? Hemoglobin is 140. I went offline, sorry. So it cannot be CI-AKI because the time period is 7 days. It cannot be more than 5 days, right? As we discussed just a few questions back. Okay. So I think this is the last question for today. A 63-year-old man presents in the respiratory clinic having referred by the general practitioner following investigation that revealed high serum calcium and a chronic cough. Chronic cough with a high serum calcium. What is the diagnosis? Can somebody just tell me? There is always
Small cell carcinoma of lung.
Okay, one is small cell carcinoma of the lungs. Yes, true, and a bit not uncommon, but another diagnosis. That is the diagnosis I'm looking for because yes, Dr. Sohail, you are very nice. Sarcoidosis. Did you get the answer from the high serum calcium and chronic cough or from the rash, the picture? Because the picture is pretty classical. If somebody knows that, then they'll get the answer immediately. Okay, you can write in the chat, and I shall see. So anyway, well done. The high serum calcium with the chronic cough is yes. One thing is cancer, the other one is sarcoid. Cancer is obviously more common. So let's see which one is it here. He's a non-smoker. So let's find out a point that they're given. Non-smoker. Immediately they rule out this lung cancer. And as doctor told, ruling out small cell lung cancer because why doctor told her is small cell lung cancer? Because of paraneoplastic syndrome associated that causes this high serum calcium, the PTH, rising PT, that only occurs in small cell lung cancer. Anyway, so he has no significant history of weight loss, fatigue, or malaise. Again, ruling out malignancy. Other than the occasional paracetamol, takes no regular medication. So otherwise fit. On examination, there are fine crepitations throughout. A rectal examination is consistent with fecal loading. So once again, no mass. Ruling out abdominal malignancy as well. Rash shown below. Can somebody tell me which rash this is? Yes, Dr. Ganesan, sarcoidosis. And just somebody tell me which rash that one is. Anything, just give me your guesses. Okay, anybody? Nobody. Okay, somebody has given out that. Sorry, I did not see. Yes, it's erythema nodosum, EN. And what are the causes of EN? Now that is the one, isn't it? Erythema nodosum causes tuberculosis, sarcoid, malignancy, commonly colon malignancy, and lung cancer. Colon malignancy or gut malignancy, right? So you see, they have given enough clues. They have told that there is no mass, so ruling out this colon or gut malignancy. They have told that there is high serum calcium with chronic cough but non-smoker, so ruling out this small cell lung cancer. They also given this no weight loss, no fatigue, no malaise, ruling out malignancy. So they have pointed that it is a sarcoid or a tuberculosis. Because it's a foreign exam, that is I am from India. Sarcoid tuberculosis is I think is 1,000 times more common than sarcoid in India. So here maybe I would have been confusing TB and sarcoid, but it's a European exam. Their tuberculosis is not very common. Their sarcoid is much more common. So there they have given this question as sarcoid only. So let's see what are the options. They have told that I'm sorry, I think the urine protein is plus plus, urine blood is plus plus, is referred for a kidney biopsy. What do you expect to be the most likely results in a kidney biopsy? It's a very difficult question. I absolutely agree, because even if you find out that it's a sarcoid, then they are told to find out what would be the biopsy finding. So biopsy finding is nothing. They have told which glomerulonephritis it is. Podocyte fusion and no change, both are findings of minimal change in nephropathy. No change is the finding of light microscopy. Podocyte fusion is the finding of electron microscopy. Okay. Focal segmental glomerulosclerosis for exam at least is associated with HIV. So that leaves us with membranous and membranoproliferative. Now, membranoproliferative glomerulonephritis, membranous glomerulonephritis. Membranoglomerulonephritis classically associated with hepatitis, with cocaine and heroin abuse, that is drug abuse, and most classically with malignancy. Whereas membranoproliferative glomerulonephritis, membranoproliferative glomerulonephritis, that is associated with the ones like sarcoid or TB. So here the answer is membranoproliferative glomerulonephritis. I think that brings us to the end of the class. These are the answer. And okay, just make a correction here. Last option is A, so it will be B. I was given 40 minutes. I think I have exceeded my time by quite a long time, but yeah, I was 15 minutes late also.
Yes, sir. Yes, sir.
Okay, so I think that brings us to the end of the session. It was a crash course, so we could have discussed a lot more details if it was a regular course, because AK is one of my favorite topics. I really like to discuss about kidney injury and CKD and hemodialysis and the different trials. But yeah, it was my pleasure.